Preventing problems. Women who intend to breastfeed but encounter difficulties that cause them to switch to formula feeding may express guilt and disappointment for months or years after the experience. Nurses can help prevent early problems in several ways. Teaching. Once women leave the birth facility, they often have no one to advise them about breastfeeding. Help prevent problems after discharge by intensive teaching during the short stay at the birth facility. Check the woman frequently as she feeds her infant so that her questions can be answered as she thinks of them. Include suggestions on how to improve positioning and techniques. Discuss common problems that may occur after discharge and offer solutions. Some facilities hold classes for groups of women during the birth facility stay. Pamphlets and trusted web resources provide another means of teaching. Nurses should teach families about community breastfeeding resources, including classes, telephone support lines, breastfeeding mothers support groups, women, infant, and children food and nutrition service (WIC) resources, and outpatient lactation consultants. Minimizing interruptions. While the mother and baby are establishing breastfeeding, keep interruptions to a minimum. Ask her if she would like visitors to wait until she has finished feeding. Hang a Do Not Disturb sign on the door and advise staff and visitors that the mother should not be interrupted. Tell the mother to use her call light to notify the nurse if she needs help or when she is ready for interruptions. Formula gift packs. The AAP and ACOG recommend against giving formula gift packs to mothers at hospital discharge because this practice may lead to an expectation in some mothers that formula will be necessary. This is contrary to the message nurses should give to parents about their ability to exclusively breastfeed. Formula supplementation. Avoid use of formula supplementation in the hospital unless there are medical indications. Avoidance of supplements of any kind during the first 72 hours is a nursing care quality measure being introduced by the Association of Women's Health, Obstetric and Neonatal Nurses, AHWAN. Supplements may lessen the success of breastfeeding because they decrease feeding from the breast and decrease milk production. A Healthy People 2020 goal is to reduce the proportion of breastfed newborns who receive formula in the first 2 days of life to no more than 15.6%. In 2016, 17.1% of breastfed infants received formula before they were 2 days old. Teach mothers that supplementing with formula will not necessarily result in their getting more sleep during the night. Breastfed infants do not need water or glucose water because they will interfere with adequate intake of breast milk. Insufficient milk supply. One of the major reasons for early weaning to formula is parents' perception of insufficient milk supply. Women with positive attitudes towards breastfeeding and confidence that they will produce enough milk are less likely to wean early because of perceived insufficiency of milk. Explain the normal course of breastfeeding and the methods of handling problems to help mothers feel more confident in their abilities. Teach the parents how to assess swallowing and nutritive suckling. Discuss ways to determine whether the infant is receiving enough milk. Suggest that the mother count the number of wet and soiled diapers to help her determine whether the infant is receiving enough milk. A simple chart can be used to record the quality and total number of feedings per day, along with the number of voids and stools each day. Infants should have at least 3 wet diapers and 3 stools a day by the 3rd day. After that time, a normal breastfed infant should have at least 4 or more stools daily. The baby who is breastfed well will have copious yellow stools by day 6. There should be at least 6 wet diapers per day by day 4. Intake also can be gauged when weight gain is assessed at well baby checkups. After the initial weight loss following birth, infants generally gain approximately 20 to 30 grams, 0.7 to 1 ounce, each day during the first 3 months. Common causes of decreased milk supply include ineffective suckling by the infant, feedings that are infrequent or too short, maternal fatigue, low maternal thyroid function, preterm or late preterm infants, and some medications, including oral contraceptives containing estrogen. Intervene appropriately if any common causes are present. Although women were once taught to drink large quantities of liquids to maintain milk supply, fluid intake sufficient to satisfy the mother's thirst and to keep her urine light yellow is adequate. Because the breasts are soft and the mother does not see large amounts of milk during the first few days, she may believe that little or none is present. This may lead her to give the infant formula before or after the feeding, decreasing milk production. Teach mothers who need to increase milk supply to feed more often and to hand express or use a breast pump after feedings. If problems persist, refer the woman to a lactation consultant. Lactation professionals are often available in the birth facility and in the community. They can help with breastfeeding techniques and special problems. Getting help from family. Fathers often feel there is nothing they can do to help the mother during breastfeeding. Give suggestions on how the father can be involved. Helping the mother recognize early hunger signs can alert the mother to get ready to feed. Fathers can prepare the infant for feeding by changing the diaper and calming the infant. Assisting the mother to position the infant so both mother and baby are comfortable, and burping the infant after feedings are other methods of support. Caring for other children, preparing meals, and helping with housework can help mothers get more rest. Increasing confidence. Use every opportunity to offer praise and reinforcement to the woman's ability to breastfeed her infant. Point out the infant's positive response to the mother's handling and feeding. Mention the improvements she makes in recognizing hunger cues, positioning, latch-on, and other aspects of care. The nurse's support and encouragement will help the woman feel more confident with each feeding and may lead to a longer duration of breastfeeding. Providing resources. Women who stop breastfeeding before they originally planned often cite nipple pain, problems with latch-on, belief that their milk supply was insufficient, and need to return to work as their reasons. Give them contact information for lactation consultants, the local La Leche League, and other breastfeeding resources in their area that may help them continue breastfeeding. Providing written material and internet resources is also helpful. Evaluation. Evaluation of intervention should be continued throughout the birth facility stay. Before discharge, the infant should be feeding well with nutritive sucking and audible swallowing at least 8 to 12 times per day. Mothers should be taught to evaluate feeding by monitoring for a comfortable latch, listening for the infant to swallow while feeding, and watching the baby for signs of satiety. The woman should correctly demonstrate feeding techniques and voice her satisfaction with breastfeeding and confidence in her ability. Satisfaction and confidence are major determinants of whether she continues breastfeeding at home. Common breastfeeding concerns. Because mothers may be discharged from the birth facility before problems arise, nurses should teach them how to prevent and treat common concerns. When the mother seeks help for problems that have developed after discharge, the nurse should ask what the mother has tried to solve the problem and whether she has used any complementary or alternative therapies. The safety of any therapy should be determined. The mother may have used other herbs to promote milk production. Research on the use of these therapies is inadequate. Therefore, she should be referred to a healthcare provider for information before using any substances, because some may be harmful. Problems may be divided into those originating with the infant and those pertaining to the mother. Infant problems. Infant problems require prompt attention to ensure successful breastfeeding. Sleepy infant. During the first few days after birth, infants often sleep longer than expected or fall asleep at the breast after feeding for only a short time. They may be tired from the birth process and may not recognize or respond appropriately to hunger. The nurse should show mothers how to arouse sleepy infants for breastfeeding. See Patient Teaching, Solutions to Common Breastfeeding Problems. All right, so this is an excerpt from that table on page 622. So the problem is sleepy infant, and here's the list of solutions. If your baby goes to sleep during the feeding and has fed for just a few minutes, try the following. Undress the baby, except for the diaper, and place the infant against your skin if you have not done this already. Rub the baby's hair or back gently, stroke around his or her mouth, or shift the baby's position slightly to see if he or she will wake up. Remove the baby from the breast. Rub the infant's back to bring up bubbles of air that may cause a sensation of stomach fullness. Rubbing the back also stimulates the central nervous system and arouses the baby. Change the diaper. Express a few drops of colostrum onto the nipple. The baby tastes the colostrum when the nipple is offered and often resumes suckling. Wipe the face gently with a lukewarm washcloth to help the infant wake up. If your baby cannot be aroused with a few of these gentle techniques, a longer sleep period may be needed. Let the infant remain skin to skin with you for another half hour, then begin again. Watch the signs the baby is in a lighter phase of sleep and can be awakened more easily. If infants start the feeding fully awake, they are more likely to stay awake to finish the feeding. Pointing out the various behavioral states to the mother helps her develop a greater understanding of her infant and recognize when her attempts to feed will be most successful. When the infant falls asleep during feedings, the nurse should evaluate whether the infant has fed adequately, should be awakened to feed longer, or should be fed again sooner than usual. Emphasizing that wake-up techniques should be gentle is important. The mother should avoid techniques that are excessively irritating to the infant, because feeding should be associated with pleasurable sensations. Infants who continue to be excessively sleepy or nurse poorly need further evaluation. Poor feeding can be an early sign of complications such as sepsis. Patient teaching. Is my baby getting enough milk? Your baby is probably getting enough milk if you hear the baby swallow frequently during feedings. It sounds like a soft ka or ah sound. You see nutritive suckling, a smooth series of suckling and swallowing with occasional rest periods. This is different from short, choppy sucks that occur when the baby is falling asleep and not getting milk. After the first few days, you may feel a tingling on your nipples each time a new letdown reflex occurs. This sensation is followed by more nutritive suckling as the infant swallows the increased milk available. Once your milk has increased, your breast is getting softer during the feeding. However, your breasts do not have to be hard and gorged for you to have enough milk. You can see milk in the baby's mouth or dripping from your breast occasionally. You feed your baby 8 to 12 times every 24 hours. More milk is produced when you nurse more often. Keep track at first by writing down the quality and number of feedings each day. Your baby has at least 1 or 2 wet diapers per day for the first 2 days after birth, at least 3 or 4 wet diapers a day by day 3, and at least 6 wet diapers per day by day 4. Disposable diapers are very absorbent, and knowing whether they are wet is sometimes hard. If you are unsure, place a tissue or cotton ball inside the diaper to show even small amounts of urine. Urine should be light yellow, not dark yellow. Your baby has at least 3 or 4 bowel movements per day by day 3 and 4 bowel movements per day after that time. The bowel movements transition in color over the first week from black tarry to brown to green to yellow. Your baby seems satisfied after feedings. An occasional fussy time is not unusual and does not mean that the baby is not getting enough to eat. Well baby checkups show that your baby is gaining weight. Nipple confusion. Nipple confusion or nipple preference may occur when an infant who has been fed by bottle confuses the tongue movements necessary for bottle feeding with the suckling of breastfeeding. Some infants may refuse to breastfeed or use tongue movements that push the breast out of the mouth. Movements of the mouth and tongue are different in breastfeeding and bottle feeding. During breastfeeding, the infant uses suction to hold the nipple in place near the soft palate. The tongue cups around the nipple and areola with the tip over the lower gum. With each compression of the lower jaw, the tongue presses against the breast, causing the milk to move forward from the ducts and into the infant's mouth. To feed from a bottle, infants must push the tongue over the nipple to slow the flow of milk and prevent choking. This constant flow can be demonstrated by noting the steady drip of milk when the bottle is held upside down. The infant's lips are relaxed because there is no need to hold the nipple in place. If the infant uses the same thrusting tongue motion and relaxed lips while breastfeeding, the breast may be pushed out of the mouth. Nurses should discourage the use of bottles or formula in normal breastfeeding infants. It reduces breastfeeding time, which decreases prolactin secretion and therefore milk production. The increased time between feedings limits breast stimulation and may lead to engorgement. Early pacifier use may be associated with suckling problems and an earlier weaning from the breast for some infants. Pacifiers are advised as one way to decrease the risk for SIDS, but their use can be delayed for the first month until breastfeeding is well established. Suckling problems. Suckling problems may occur when the nipple is poorly positioned in the infant's mouth. Dimpling of the cheeks and smacking or clicking sounds may indicate that the infant is sucking on the tongue or nipple only. Some infants do not open their mouths widely enough and suck on the end of the nipple. Inserting a gloved finger into the infant's mouth helps assess suckling. The motion of the tongue should be felt as the infant sucks. The infant who is thrusting the tongue may have become confused by the use of artificial nipples, which should be avoided until the problem is resolved. The tongue should be cupped under the breast and should cover the lower gum. If the infant tends to place the tongue on top of the nipple, inserting a finger in the mouth and pressing the infant's tongue down just before latch-on may be effective. Helping the infant open the mouth wide before attachment may improve suckling. More complicated suckling problems may require assistance from a lactation consultant. Infant complications. Infant complications may be minor and cause minimal interference with breastfeeding or may prevent the infant from breastfeeding for a long period. Jaundice. Jaundice, hyperbilirubinemia, in the infant does not necessarily interfere with breastfeeding. Even when infants receive phototherapy, they usually can be removed from the lights for feedings or may be able to be breastfed with a billy blanket in place. Concern about adequate intake may be more prevalent in caring for the infant with jaundice. Insensible water loss from the skin is increased as a result of the heat and lights used in treatment and could lead to dehydration. Infants receiving phototherapy should not be given water, which may decrease the intake of breast milk. Decreased intestinal motility from insufficient milk intake allows reabsorption of bilirubin through the intestinal wall into the bloodstream, increasing the work of the immature liver. Frequent breastfeeding increases the number of stools, which aids in bilirubin excretion and provides adequate intake of protein and fluid. Prematurity. If the preterm infant cannot breastfeed immediately after birth, the mother needs encouragement and instruction on how to express her breast milk. She should be assisted in hand expression within the first 1 to 2 hours after delivery, and then in the use of a breast pump to establish and maintain her milk supply. Breast pumping should be initiated within the first 6 hours of separation to maximize long-term milk supply. Breast milk offers immunologic and nutritional benefits and is adapted to the preterm infant's needs. Formula use is associated with necrotizing enterocolitis, a serious complication of prematurity, so providing breast milk to a preterm infant can be life-saving. It also helps the mother to feel she is providing care for her infant even when she is not able to take the baby home with her. The woman can express her milk and take it to the nursery for the infant's feedings. The nurse should provide sterile containers for the woman to take home and instruct her in special nursery requirements. The container should be labeled with the infant's name and the date and time milk was pumped. Some preterm infants or those with breastfeeding problems respond well to the use of supplementary feeding devices. These consist of a container of milk with a small plastic feeding tube attached to the breast. When the infant begins to breastfeed, milk is drawn from both the container and the breast, increasing the infant's intake and motivation to continue suckling. As the infant gains weight and feeding ability increases, use of the device is gradually decreased until it can be discontinued completely. Women who provide breast milk for their preterm infants may feel something is wrong with their milk when additions such as human milk fortifier are used. They should be reassured that their milk is very important in providing nutrition and protection against infection, and that the infant needs more of some nutrients during the period of very rapid growth. Late preterm infants, born between the 34th week and the 37th week of gestation, may have difficulty feeding. Although they may look like full-term infants, they are immature. Coordination of sucking, swallowing, and breathing may be poor, and they may be sleepier than full-term infants. A lactation consultant should be involved in teaching the mother her late preterm infant special needs and monitoring the effectiveness of feedings. The infants need to be positioned in such a way that the head is supported, as in a football hold. Infants should be seen by a healthcare provider within 1 to 2 days after discharge to check the weight, adequacy of feeding, and jaundice. Frequent visits and weight checks should be made for any infants having feeding difficulties. Weekly weight checks should be performed until the infant reaches 40 weeks of post-conceptional age. Illness and congenital defects. Infant illnesses and congenital defects such as cleft palate may cause breastfeeding problems. If the mother is not able to nurse the infant at first, she will need assistance to maintain lactation until breastfeeding is possible. Referral to support groups can be particularly helpful. Some groups focus on particular congenital defects, and others focus on breastfeeding infants with special problems. Maternal concerns. Early nursing intervention can help the mother overcome common breast problems. Common breast problems: engorgement, nipple trauma, flat or inverted nipples, plugged ducts, and mastitis, infection of the breast, are common problems involving the breasts. Engorgement. Many women experience a temporary swelling or fullness of the breasts, which peaks at 72 to 96 hours after giving birth, when the production of milk begins to increase or the milk comes in. The normal temporary fullness is the result of congestion, increased vascularity, accumulation of milk, and edema. It should not interfere with breastfeeding. Engorgement may become a problem if feedings are delayed, too short, or infrequent. Engorged breasts become edematous, hard, and tender, making feeding and even movement painful. The areola may become so hard that the infant cannot compress it for feeding. An engorged areola causes the nipple to become flat, making it more difficult for the infant to draw it into the back of the mouth. Engorgement may lead to nipple trauma, mastitis, and even the discontinuation of breastfeeding. Nurses help prevent engorgement by assisting women to begin breastfeeding early and to feed frequently. Encouraging mothers to breastfeed with all infant feeding cues, even at night, ensures that the breasts are emptied regularly. The use of water and formula should be discouraged. Nipple pain. Nipple pain is common during early breastfeeding. Pain for 1 minute or less may occur at the beginning of feedings because of tissue stretching and suction of the ductules before they fill with milk. Nipple pain is common during the first week, usually peaks at the 3rd to 6th day, and resolves soon afterward. Nipple trauma causes more sustained pain. Traumatized nipples appear red, cracked, blistered, or bleeding. Minor nipple trauma can be treated by independent nursing interventions. Redness of breast tissue, purulent drainage, and fever indicate mastitis or breast abscess and require antibiotic treatment. Improper positioning or latch-on techniques and exposure to soaps, prolonged moisture from wet breast pads, or irritating creams may cause sore nipples. Using a breast pump too long or with the suction set on high may be traumatic. Flat and inverted nipples. Nipple abnormalities should be identified during pregnancy, if possible, but interventions can begin after birth if necessary. Nipple rolling just before feeding helps flat nipples become more erect so the infant can grasp them more readily. A breast pump used for a few minutes before feedings or a breast shield may help draw out inverted nipples. Plugged ducts. Although the exact cause of occlusion of a lactiferous duct is unknown, engorgement, missed feedings, or a constricting bra may be involved. Localized edema and tenderness are present, and a hard area may be palpated. A tiny white area may be present on the nipple. Massage of the area, frequent breastfeeding, heat application, and using varied breastfeeding positions are helpful. A plugged duct may progress to mastitis if not treated properly. Mastitis involves localized pain accompanied by fever, generalized aching, and malaise. Illness in the mother. It is rarely necessary for a mother to stop breastfeeding when she is ill. If breastfeeding must be temporarily stopped because of the mother's condition or the drug she receives, the nurse should help the mother hand express or use a breast pump until she resumes breastfeeding. Abrupt weaning may lead to mastitis. Drug transfer to breast milk. Most medications taken by the mother are compatible with breastfeeding. Some drugs interfere with milk production. Therefore, both prescription and over-the-counter drugs should be approved by the healthcare provider. In many cases, another drug can be substituted for one that adversely affects the infant. If a mother must take a drug that will be harmful to the infant, she should pump her breasts and discard the milk while she is taking the medication. Once the drug clears her bloodstream, she may resume breastfeeding. Some drugs may not reach the infant in harmful amounts if taken after a feeding or at night when there is a longer time between feedings. The U.S. National Library of Medicine has a website for information about drugs during lactation. Conditions in which breastfeeding should be avoided. In some situations, such as a mother's serious illness that can be transmitted to the infant, breastfeeding is contraindicated. Women who take methadone or buprenorphine for opiate addiction are allowed to breastfeed because only minimal amounts of the drugs pass to breast milk. Other types of drug abuse, active untreated tuberculosis, HIV infection, galactosemia, maternal chemotherapy, and mothers who must take drugs that are unsafe for the infant are situations in which breastfeeding is not advised. Mothers with hepatitis A, B, or C may breastfeed. Infants of mothers with hepatitis B should receive hepatitis B vaccine and immunoglobulin. Herpes simplex does not preclude breastfeeding if the mother does not have a lesion on her breast and uses thorough hand washing. Women who smoke can breastfeed but should stop smoking if possible or not smoke around the infant. Previous breast surgery. Women who have had surgery for breast reduction, augmentation, or other conditions may have difficulty with lactation. The ability to produce and transfer milk to the nipple depends on the surgical technique used and the amount of tissue involved. Surgery may disrupt the neural pathways, ducts, and blood supply. Some women can breastfeed without problems. Others may be able to do so by pumping to help build up milk supply or using a supplementation device when the breasts are unable to produce a sufficient amount of milk. Women with pierced nipples should not have difficulty with breastfeeding. They should remove the rings or studs before feeding the infant. Employment. Although some women remain at home for 6 or more weeks after giving birth, others must return to work earlier. With some advanced planning, breastfeeding can be efficiently combined with working. Breastfeeding classes and support groups are often helpful in providing practical advice on how to merge employment with lactation. The mother will need to procure a breast pump. The expense of a pump is covered under most insurance plans. A week or two before she returns to work, the mother should use a breast pump once or twice a day to practice pumping her breasts and to build up a small supply of frozen breast milk. The breast should be pumped after the infant has nursed. Giving the infant breast milk from a bottle, occasionally, about 2 weeks before returning to work, makes the transition smoother. Most working mothers use a pump 2 or 3 times a day during lunch or breaks at work. The woman needs a clean, private place to pump. A national goal is to increase the proportion of employers that have worksite lactation support programs. U.S. law now requires employers to provide reasonable break time for a nursing employee to express milk for 1 year after her child's birth. A place to express milk, other than a bathroom, is also to be provided and must be shielded from view and intrusions. The milk should be refrigerated or placed in an insulated container with ice to be used for the next day's feedings by the caregiver. Breastfeeding just before the mother leaves for work and again when she returns home keeps the time between feedings at a minimum. Frequent breastfeeding throughout the evenings and on weekends helps her maintain her milk supply. Some mothers choose to use formula during work hours but breastfeed when at home. They should prepare for this by gradually eliminating the feedings that occur during work hours and substituting a bottle. Although the total milk supply is diminished, breastfeeding can continue in the mornings and evenings. Milk expression and storage. When milk expression is needed, the nurse helps the mother use hand expression or a breast pump. Hand expression. Hand expression can be performed without other equipment and is often a more effective way to collect colostrum. It also can be used in emergency situations when a mother is separated from her baby and may be done without electricity or a pump. Hand expression or manual pumps are also useful for the mother who wants to save breast milk for another feeding occasionally, or whose areolae are so engorged that the infant cannot grasp them. Use of a breast pump. The mother who plans to pump her milk for a prolonged period should use an electric breast pump. Battery-operated pumps are small, portable, and relatively inexpensive for short-term use. Large, electric, hospital-grade pumps can be rented for home use. They are more efficient than hand pumps or battery-operated pumps and are indicated when the mother plans to pump for a long time. A double pump allows the mother to pump both breasts at once, saving time and increasing milk production. A woman who cannot breastfeed her infant should be instructed in the use of the breast pump as soon as possible after birth, but at least within the first 6 hours. She should pump her breast as often as the infant would nurse, or at least 8 times a day if she plans to breastfeed for a prolonged time. Sessions should last approximately 15 to 20 minutes. The mother should wash her hands before using the pump and before preparing the pump milk for storage or feeding. Breast massage and application of heat before pumping help initiate the flow of milk. Massaging the breast during pumping may increase the volume of milk obtained at each session. Pumping after the first morning feeding often produces the greatest volume. Relaxation during pumping increases volume, but tension or discomfort may reduce the output. The mother should plan enough time for pumping so she does not feel hurried, because that would increase tension and decrease the output. The amount of suction should be set at low level in the beginning and gradually increased if necessary. Too much negative pressure traumatizes the breast. If the woman needs to increase her milk supply, pumping more often and with breast massage and hand expression is more effective than longer sessions. The pump should be cleaned according to the manufacturer's instructions after each use. Milk storage. Milk should be stored in clean, sterile for a hospitalized infant, glass or rigid polypropylene containers with a tight cap. A nipple should not be used to cover the container during storage because the hole allows passage of organisms that can contaminate the milk. Fresh, unrefrigerated breast milk should generally be used within 3 to 4 hours of pumping. Under very clean conditions, using it within 6 to 8 hours is acceptable. It may be stored in a refrigerator at 4 degrees Celsius, 39 Fahrenheit, or below for 72 hours in usual circumstances, or for 5 to 8 days under very clean situations. Milk that is fresh or has been refrigerated rather than frozen should be used as much as possible, so the leukocytes are available for the infant. If the milk is to be frozen, it should be placed in the back of the freezer and kept at minus 17 degrees Celsius, 0 Fahrenheit, or below. It should optimally be used by 6 months, although use within 12 months is acceptable. Milk should be frozen in amounts that are likely to be used for one feeding. Containers should be marked with the date and oldest used first. Newly pumped milk should not be added to containers of previously pumped milk. Breast milk can be thawed and warmed by holding the container under running water. Cool water should be used first to defrost it, then the milk can be warmed by placing it under warm running water or in a bowl of warm water. It also can be thawed in the refrigerator and used within 24 hours. It should not be refrozen. Milk should not be heated in a microwave because the microwave heats unevenly. The infant might be burned because the container may be cool, but the milk may have hot spots. Thawed breast milk should be gently inverted a few times to mix the foremilk and hind milk. Milk that is not finished in one feeding should be discarded within 1 hour. Breastfeeding after multiple births. Mothers who have more than one newborn have many questions about breastfeeding and need help and support from nurses and family members to be successful. Explain to the mother that her milk supply adjusts to the demand and that she can produce enough milk for her infants. Breastfeeding each baby 8 to 12 times per day to build up the milk supply is important. If the infants cannot breastfeed at first, the woman will need help hand expressing and using a breast pump. If the woman decides to feed two infants simultaneously, the nurse helps position them in the football clutch hold, cradle hold, or a combination of both. She should be encouraged to eat well, get enough rest, and ask for help from family and friends. Weaning. Mothers are sometimes subjected to opinions and pressure from family and friends about weaning. There's no one right time to wean the infant. The AAP suggests exclusive breastfeeding for at least 6 months, and then to add complementary foods and continue to breastfeed till the baby is at least 1 year old and as long after that as both mother and baby desire. Mothers choose to wean their infants for various reasons. The nurse should provide information so women can make informed decisions about weaning and should support the woman once her decision is made. Explaining that even a short period of breastfeeding offers her infant many advantages is reassuring. Mothers may need help in planning a slow weaning process to help avoid engorgement and allow the infant to become accustomed to a bottle or cup gradually. Mothers who are not in a hurry to wean may allow the infant to take the lead. Omitting one breastfeeding session a day and waiting several days or a week before omitting another will allow the mother and the infant to adjust to the change more easily. Weaning too rapidly increases the risk for plugged ducts or mastitis. Infants who are weaned before 12 months of age should be given iron-fortified formula instead of cow's milk. Home care. Some infants have not breastfed well by the time of discharge from the birth facility, placing them at risk for failure to gain weight, dehydration, and hyperbilirubinemia. Problems with engorgement and sore nipples are more likely to occur after discharge. These families need continued support by nurses during home, clinic, or office visits. The infant should be seen by the physician or healthcare provider 3 to 5 days after birth or within 48 hours of discharge and again at 2 to 3 weeks of age to assess for any problems that might occur early after discharge. A mother may be concerned when her infant suddenly seems to want to nurse much more often. She may assume she is not producing enough milk. Nurses can teach mothers this behavior shows their infants are experiencing growth spurts. These growth spurts occur at approximately 10 days, 2 weeks, 6 weeks, 3 months, and 6 months after birth. Guidance for dealing with breastfeeding problems can be discontinued after discharge by referring the mother to lactation consultants or organizations such as La Leche League, a support group that gives assistance to breastfeeding mothers. La Leche League groups are available in most communities and are available on their website. Support groups also may be provided by the birth facility. Formula feeding. According to the AAP, breastfeeding and human milk are the normative standards for infant feeding and nutrition. However, some parents make an informed decision to formula feed. In addition, there are some rare health conditions in which breastfeeding is contraindicated. Parents who are formula feeding need to be taught how to safely prepare, handle, and feed formula to mitigate some of the risks of this feeding method. Application of the nursing process. Formula feeding. Assessment. Assess both the mother and the infant during the feeding process. Mother's knowledge. Assess the mother's knowledge of formula feeding. Ask her if she has fed an infant before and whether she has questions. Observe her technique during the initial and subsequent feedings. Note how she holds the infant and the bottle, and evaluate her burping technique to identify areas in which she seems unsure. Infant feeding behaviors. Point out infant feeding cues, which are the same regardless of how infants are fed. Waiting until the infant is frantic may result in a feeding taken too fast, with excess swallowing of air or choking. Assess the way the infant sucks to identify problems. Identification of patient problems. Because improper formula preparation and feeding techniques could harm the infant, the parent's lack of understanding of formula preparation and feeding techniques is a potential patient problem that could lead to a potential for injury to the infant. Planning expected outcomes. The mother will demonstrate correct techniques in holding the infant and bottle during feedings and will correctly describe how to prepare formula and the frequency of feedings. Interventions. Teaching about formula. The parents must learn about types of formula available and how to prepare them. Types of formula. The physician or nurse practitioner prescribes the type of formula the mother is to use. Infants should receive iron-fortified formula. Formula may be purchased in 3 different forms: ready-to-use formula, concentrated liquid formula, and powdered formula. Ready-to-use formula. Ready-to-use formula is available in bottles to which a nipple is added or in cans to be poured directly into a bottle. It should not be diluted. The container should be shaken and the top of the can washed before opening and pouring it into a bottle. Although expensive, it is pre-sterilized and practical when traveling, when there is difficulty in mixing formula, or if the water supply is in question. Refrigeration is not necessary until the container is opened. An open can should be refrigerated and used within 48 hours. Concentrated liquid formula. Explain to the parents how to dilute concentrated liquid formula. Equal parts of concentrated liquid formula and water are mixed together and poured into a bottle to provide the amount desired for each feeding. Once again, the can should be shaken well and the top washed before opening. Opened cans should be stored in the refrigerator and used within 48 hours. Powdered formula. Powdered formula is more economical, but because it is not a sterile product, can harbor pathogens that cause significant illness in infants. Therefore, it is not recommended for infants who are preterm, less than 2 months of age, or immunocompromised. To help kill pathogens that may be present in the powder, powdered formula should be mixed with boiling water that has not been allowed to cool for more than 30 minutes. Usually 1 level scoop of powder is added to each 60 milliliters, 2 ounces of water in the bottle. Formula should be well mixed to dissolve the powder and make the solution uniform. The bottle should then be rapidly cooled to a temperature safe for feeding by placing the bottle under running cold tap water or placing it in a cup of cold water. Because prepared formula is an ideal growth medium for pathogens, new formula should be prepared for each feeding and used immediately. However, for practical reasons, several feedings can be prepared at once and refrigerated for no more than 24 hours. Any prepared formula left at room temperature for more than 2 hours should be discarded. Equipment. Many different types of bottles and nipples are available. Mothers may use glass or plastic bottles, or a plastic liner that fits into a rigid container. Selection of type of bottles and nipples depends on individual preference. Although bisphenol A, BPA, was once a concern, it is no longer used in baby bottles in the United States. Preparation. Discuss preparation of formula with the mother. Instruct the mother to wash her hands as well as the top of the can and the can opener if needed. Infection may occur if the equipment, milk, or water used for preparation is contaminated. Emphasize the importance of following the directions on the label when mixing the formula. Improper dilution of the formula may cause undernutrition, imbalances of sodium level, and an excessively high renal solute load, which can be dangerous to the infant. If water from a well is used, it should be tested for high levels of nitrates, which can be harmful to infants. Bottles and nipples can be washed in hot, sudsy water using a brush to clean well, then rinsed and allowed to air dry. They also may be washed in a dishwasher. The formula and water are poured into the bottles, which are then capped. Emphasize that the proportion of water and liquid or powdered formula must be followed exactly to avoid causing illness in the infant. Explain that if safety of the water supply is questionable, sterilization is necessary. All equipment is washed and rinsed well before beginning. The equipment needed for the procedure is boiled for 10 to 12 minutes in a sterilizer or deep pan. Water for diluting the formula is boiled separately. The bottles are then assembled using sterilized tongs. The formula and boiled water are added, and the bottles are capped and refrigerated until needed. Prepared bottles should be used within 24 hours. Explaining feeding techniques. Positioning. Show the parents how to position the infant in a semi-upright position such as the cradle hold. This allows them to hold the infant close in a face-to-face position. The bottle is held with the nipple kept full of formula to prevent excessive swallowing of air. Placing the infant in the opposite arm for each feeding provides varied visual stimulation during feedings. Burping. For the first few days, the infant should be burped or bubbled after every 15 milliliters, 0.5 ounces of formula. Gradually, the infant is able to take more formula before burping and should be burped halfway through feeding. Show the parents how to burp the infant over the shoulder or in a sitting position with the head supported while patting or rubbing the infant's back. Frequency and amount. Instruct the parents to feed the infant every 3 to 4 hours, but to avoid rigid scheduling and take cues from the infant. Hunger signs are the same as for breastfed infants. Teach the parents to begin feeding 15 to 30 milliliters, 0.5 to 1 ounce, at a time during the first 24 hours, then gradually increase by 15 milliliters, 0.5 ounce. The baby should not be forced to finish a bottle. Cautions. Instruct the mother not to heat formula in a microwave oven because the heating will be uneven. This may result in some parts of the liquid being very hot, even when the outside of the bottle feels only warm. Formula can be heated by placing it in a container of warm water for 5 to 10 minutes. Suggest that the mother test the formula temperature by allowing a few drops from the bottle to fall on her inner arm. Sometimes formula flow is too fast for infants. If this occurs, the infants may choke, gag, sputter, drool, or bite the nipple. Some infants suck without stopping to breathe frequently enough. To provide a rest period, the mother should tip the baby forward to stop the flow of milk. Caution parents not to prop the bottle. Propping increases the likelihood of choking if regurgitation occurs and eliminates the holding and cuddling that should accompany feeding. Some mothers put an infant to bed with a bottle propped. This not only increases the danger of aspiration, but also allows milk to pool in the mouth. Prolonged contact of teeth with milk promotes growth of bacteria and leads to cavities once teeth erupt. Otitis media is also more common in infants who sleep with a bottle or feed from a propped bottle. The parents should not try to coax the infant to finish every bottle because it could cause regurgitation and excessive weight gain. The mothers should not save formula from one feeding to the next because of the danger of rapidly growing bacteria. Any formula not used within 1 hour should be discarded. Infant variations. Infants vary in their feeding preferences. Some infants drink from the bottle reluctantly. Although formula is usually given at room temperature, some infants take heated or cool formula better. The mother of a sleepy infant needs to use the same wake-up techniques described for the breastfeeding mother. Angling the tip of the nipple so that it rubs the palate triggers the suck reflex in most infants. It may take patience and persistence to find the most effective techniques. Evaluation. The mother should hold the infant and bottle correctly during feedings. She should be able to correctly describe formula preparation and the amount and frequency of feedings.